Welcome to Q&As. This month we're giving the third in our series on memory. And today we're going to be talking about memory care. I'm delighted to have back the same guest that we had last month, Dr. Shambhala from
Hello.
the Medical Center. Welcome, Dr. Shambhala. And Kathleen Taylor, who is our social work manager. And welcome, Kathleen.
Thank you.
We're talking today about memory care, which involves really the treatment and support and care for residents who are fairly severely memory impaired. And we're going to be emphasizing today care in independent living. So Kathleen, let's talk a little bit today about what it is that you as a social worker and you, Dr. Bala, as a physician, are doing with and for residents in this kind of situation.
Yeah, that's a big question because there's a lot, that we want to be able to do. We know that when people have a dementia diagnosis or an Alzheimer's diagnosis, that the illness is progressive. So we anticipate that there'll be changes with the person along the way that are going to impact the way that they're able to live their lives. And if they have a spouse involved or a family involved in that, those changes are going to impact the caregivers as well. So for people that that have this diagnosis and are wanting to stay in independent living, we try to put the supports in place that will allow them to continue to have good quality of life and be able to have their needs met, whether they're emotional or physical needs.
Do they tend to be both?
Absolutely, absolutely. From all different kinds of directions. The illness itself impacts the person's cognition, but also their mood, which can also lead to behavioral changes, behavioral disturbances. The physical part, people will begin to lose function and not be able to independently take care of their normal activities of daily living, as we say. And then if there is a caregiver involved, then the responsibilities associated with caregiving have an impact as well on not only the emotions, it's kind of the stress has an impact on the person emotionally, but also sometimes physically too, because stress is actually, as you know, a physiological reaction too. So we are looking at being able to support both the resident and if they have a spouse, the resident with the diagnosis, and if they have a spouse or a related caregiver, that we were wanting to support them both.
All right, so you're looking at both caregiver and the individual. You have indicated in the past, Kathleen, that this is a team approach in terms of the way you're dealing with residents and their caregivers. Tell me who is on the team and how the physician medical center also is involved in this.
Right. Well, definitely the physicians in the medical center are key to this, and Dr. Bala will be able to educate us on that part. But we have, as part of our team, the social workers, of course, who are doing more of the case management, but we have all of our rehab team, physical therapists, occupational therapists, and we've spoken about speech therapy and the cognitive rehab. We have certified home health that can also provide nursing as well as rehab if the person is homebound. And then for the outpatient rehab, if people are able to get to those services. We have our home support, which if a person needs more support in the apartment setting, support with physical care, but also maybe just companionship and having someone to go out and about in the community with them. That's a resource. We have our intermissions program, which is a daycare program for people that can provide socialization and enrichment. We have our creative art therapist, which is music therapy and art therapy that we are trying to bring more often to our residents. The medical center has our mental health nurse, that can also provide support. So I hope we haven't forgotten anything. Let me see. Well, definitely hospice is also a service that we have that as the disease progresses at end stage would also be an appropriate and really valuable resource for our residents.
So that whole spectrum
That's
is
the whole
available to
continuum.
individuals and to their caretakers.
That's right. That's
Uh,
right.
in independent living.
That's right.
All right. Now, most of these services, such as OT, PT, speech pathology, these are ordered by the physician, and you then, as the case manager, are working with the medical center and the physicians to get these orders. Is that the way it works?
Absolutely.
And set up the whole program. Dr. Bala?
In order to have a good understanding, or at least try to have a fair understanding of the disease process of dementia, is that it is, like Kathleen said, it's a progressive disease, and there is a expected cognitive and functional decline. It's a spectrum of decline. However, it does not happen in the same way to all the individuals with dementia. It's different for different individuals.
Patterns.
The patterns. For some individuals, it's more intense memory loss and intense cognitive decline, but physically they'll be able to walk, will be able to manage their bowel and bladder functions. But some of them would have more urinary incontinence, more stool incontinence, will not be able to manage their bowel and bladder. And this can go with the cognitive decline. And then eventually they slowly even have trouble walking, trouble transferring from bed to chair, and will not be able to understand how to manage their activities of daily living, mainly, get up, have a wash, go to the bathroom, go to the toilet, clean themselves afterwards, even how to dress themselves. They probably would, it'd be very interesting to notice that they may put their underwear outside their pants, or pants first and the underwear. So they would need help in all those things. So that's where it becomes a challenge for the caregiver. So they are not only emotionally taxed, but they're also physically taxed to help their loved one. They have to do everything at one point for them. So that's how there is a physical and also an emotional stress. And how the doctor helps here is sometimes during the disease process, this is how the disease progresses. It's what we call a step ladder kind of decline. So there is a baseline, and then there is a steep decline, and then they might improve a little bit, but they never come back to their original baseline, and then what they hit is what we call a new baseline. So when there is a steep decline, that's when the caregiver would approach the physician. Something is wrong. He or she is not acting himself. So that's when the medical center gets involved in checking for all possible causes that, namely urinary tract infection. They might have a bronchitis, whatever, even a joint pain. Because we have to remember that people with dementia are unable to express themselves. What their problem is. What we see is they're just acting out. Either they stop walking. It could be because they have a joint problem. Or they slowly decline, that they become so weak they're unable to. The legs are unable to support their body. So that's when we give referral to physical therapy. Sometimes they had a fall. So that's when we give a reference to occupational therapy. And also they develop difficulty in eating. That's when we give referral to occupational therapy for adaptive devices. So, all these things this is how we come as a team. It can be, after we have exhausted all the treatment options that can help the resident in terms of treating their clinical illnesses, It can happen afterwards or in conjunction. Sometimes we wait because we want the you cannot tax a sick individual to do therapy. Who wants to get out of bed when you have a cold or when you have some kind of an illness? So we wait for that, and once they are more stable clinically, then we get all these therapies involved. However, expect the individual not to go back to their original baseline. He might get a little bit better, but be a little more decline than before.
Dr. Bala, you had mentioned in the last program that there were certain medications that slowed the progression. Is this true even at these late stages of dementia?
Usually they are not started at the point where the person is have severe dementia. When you say severe dementia, is when they have such intense cognitive decline that they are not able to initiate and perform an activity like dress themselves. They don't know how to dress themselves. So when they reach that point, that's when we call, we think they have severe dementia. At that point, the medications that are started to slow down the progressions are not usually initiated at that point because it's not very effective. It's effective when it is started at an early stage, when you have few signs of cognitive decline and memory loss. However, if these medications were started 10 years ago, 5 years ago at a very early stage, then they are kept. They're not stopped.
They're continued.
They're continued. They kept on board, and then what happens is when they reach a really, like Kathleen said, the end stage, where they are unable to even recognize themselves, who they forgot who they are and have no control of their functions, then we stop those medications because they have no more benefit at that point. And there are certain, with dementia, there is mood disorders. It could be depression, anxiety, or psychotic behavior or psychosis when the resident is delusional and or have hallucinations. So at that point, in order to help them control their moods and behavior, antidepressants, anti-anxiety medication, and antipsychotics are prescribed and started for these individuals, and they have to be constantly monitored. That's how the physician is involved to monitor these medications, monitor their side effects, do the necessary lab tests to monitor, so that the blood tests are normal, because these medications can affect. Sometimes they need to be adjusted so that they get the optimal effect, or they provide the optimal effect for the individual, and also needs adjustment so that the amount of side effects is reduced. So both, to give the benefit and also appropriate benefit. The dose gives the appropriate benefit and also gives the least side effect. So so this is where the physician is involved. That's if they are in the independent living, then the physician sees them in the medical center, periodically, depending upon their needs, even once a week or once a month.
So you're monitoring both the physical and the behavioral aspects of the. Are you also looking, Dr. Bala, when a resident comes in who has fairly severe dementia, does their caregiver also come in with them, and are you talking to both?
Absolutely. It's very difficult to take care of an individual with dementia in the independent living, because they do need care. If they do not have a caregiver in the independent living, then the recommendation is to move into the Garden Ridge, the memory care unit, or the long-term care unit, depending upon the appropriateness. So it's very important that they have a caregiver. It's usually the spouse. And we do monitor the spouse's needs as well. We do ask the spouse. That's called a caregiver stress. So, are you okay? Is there something that we can do for you to make this better? We do sometimes, if we if the physician senses that, see, this is how it goes across the board. You know how social work gets in touch with the physician to get some referrals if they think you know, if the resident needs. The physician reaches out to the social worker saying, hey, I really think that this a spouse, the wife or the husband is really stressed here. I had a talk with her. Could you go and kind of, you know, get more details, investigate so that we can support her, because if she falls sick, then the patient with dementia is has no support. So it's of no benefit.
Shall we ask Kathleen now what she does after? Now, Dr. Bala has said to you, this caregiver looks to me to be really stressed out. Mm-hmm. And so, Kathleen, what would you do in that case?
Well, the social worker would go in and, as Dr. Bala said, do a complete assessment to determine what, you know, what's going on.
How would you do that?
Well, we have different kinds of assessment tools that we do.
All right, so you would use your tools.
Yeah, you know, it's basically, I've used the term before, but it's a holistic assessment. Yes. To just see, you know, how the person's doing. But a lot of it is going to be about emotionally how the person's doing. You know, what their stressors are in terms of the emotional impact of caregiving on them. Dr. Ball has already sort of done the physical to determine whether there's some things going from a medical standpoint that can be addressed. And also, if we identify that there are some problems with mood, if the caregiver themselves is starting to develop some depression, then that's something that the physician or the mental health nurse can address as well. So we just try to figure out, you know, how to support that person, whether it's just, so, you know, some counseling in terms of how that person's adjusting to caregiving, some of the feelings that they're having about, you know, what it feels like to have their spouse going through these changes and how they're able to cope with that. And then just actually, is there physical supports that we can put in place? Does that caregiver need to hire somebody, a private duty aide, for example, to come in part of the day and provide them with some assistance? So
you would encourage that kind of thing?
Absolutely.
Is there any relief?
Yeah, well, we know that we can provide some respite, whether it's, you know, a paid caregiver in the apartment that would be able to allow the caregiver to get out and do whatever they enjoy doing, you know, whether it's, you know, to play bridge with some friends or have dinner or whatever, to be able,
or even go to a doctor's appointment.
Absolutely.
Because they have to take, you know, what we periodically see is the caregiver completely neglects her health because he or she is so consumed in taking care of their loved one with dementia. Yep. You know, because they would need more. It's very interesting to see that the patients or residents with dementia fall sick more often because they develop certain deficits in their bodily functions, like, you know, they have swallowing problems, and then they have to go focus on that, you know, have tests or approach another consultant or even go to speech therapy to get some help with that. So there are different things they might, their medical needs increases. So they are so consumed in taking them to different doctors, giving their medication, giving care, they put their health on hold.
All right.
So
that makes sense.
That's when.
So physically, in addition to having psychological and emotional needs, then you're saying that there's a toll physically as well. Talk about respite and exactly what it is you can help provide here.
Well,
you're talking about the caregiver.
If there's a caregiver, then definitely we can help them decide if they need somebody to just come in periodically into the apartment.
A few hours a day or week or something.
But a lot of times, you know, we definitely encourage people to take that vacation, you know, to go visit family. So if that's the case, then more of a 24-hour caregiving situation is in order, then Garden Ridge is able to accommodate a resident as a respite care. stay
On a short-term
basis. And that, I mean, it is private pay, so it's not covered, unfortunately, by insurance. Though some long-term care insurances might pay for a portion of that, but not by Medicare. But that, you know, that's definitely something that will help the caregiver to think about and encourage them, as Dr. Bala was saying, to really take care of themselves as well, because their spouse needs them. And so they need to stay strong, and they need to stay balanced, and, you know, really be able to maintain a good energy.
So that kind of arrangement can be made for a day, for a week, for a month, varying lengths of time?
Absolutely, yeah. Just, you know, you can...
That's a wonderful service, isn't it?
The respite also is there for the patient themselves. I tell you how that happens. So when they are going through that steep decline,
they benefit is what
as well, because when they go through that steep decline, see, this is where they are in that twilight zone. They do not qualify to be admitted in the hospital, but they're too ill to stay at home. So then we get them into the skilled unit in the nursing home or Garden Ridge. The advantage of being there, they're not only giving a break for the caregiver, a respite for the caregiver, but a respite for themselves, because they get complete nursing care there, or full-time nursing care there, and also can utilize the physical therapy and the occupational therapy that's available there. So it's really a good place for them to get stabilized and go back home. And the advantage of being in Green Springs is that it's so the proximity for the caregiver. They can come and visit them. It's just, you know, they just walk over there. They can have a meal with their loved one, and then they can go back. Sometimes it's very stressful for the caregiver. I want to keep him home, and I remind them, the Green Spring, the whole campus is your home. It's just that now you're in 2 separate bedrooms. It's just that one is a little far away. He's no more in the next room or in the same room. So you can still walk. When we put things like that, then the caregiver is more comfortable in having them in the nursing home.
Yes,
so you can have respite in 2 places, one in your own apartment, bringing all the services, like Kathleen said, to the apartment. The other one is to have it more contained in one place where everything is available in that. So you go to that place to have respite, or you get respite in your apartment.
And another actual added benefit of the respite care sometimes is for caregivers or families who are struggling with the idea of what the best environment is for the person with dementia. Sometimes that respite stay can kind of make it seem less scary, and they can start to get a comfort level with what it would be like if the person were to continue to stay in Garden Ridge.
Almost a trial.
A little bit to help sort of get over the hump a little bit in terms of, you know, what's the right decision to make, and if they can sort of visually see that person is able to go there, and it's not as horrible of an experience as they had maybe anticipated, that can pave the way for the next step in terms of decision making about how to meet the care needs the best way.
And that happens too, sometimes when the resident goes to the nursing home for the respite, and then it becomes apparent that that the resident needs all these needs, and that they can be met in the nursing home. Then sometimes the family and the makes the decision to continue or let the resident continue their stay in the long-term care unit in the nursing home. So that's an advantage too, to go there as a respite, and if it's appropriate, they can continue there. So it helps them to get a first.
Everybody gets more used to the idea. Is it difficult for residents with severe dementia to change environments sometimes?
Absolutely. So that's the advantage of aging in place. You know, bringing the care. The advantage of the resident being in the apartment is they are in their familiar environment, and they're close to their loved one. The advantage of being in the nursing home is that you get all the care in one place, and it's in a contained setting. The staff is trained to meet the needs of the resident and
Physical
and
mental.
emotional. More importantly, emotional. Direct and redirect behavior, engage them. In a different ways. They have they have their own programming there, so it's more structured. And since it's more structured, the resident knows what to expect. Where if in the independent living, they are among people with no cognitive impairment, so there are different settings that can disturb them. And so the disadvantage being in the nursing home is the distance from their familiar environment and also their loved one. But eventually they get used to it. And they love it there. So, but that would be a kind of a little hurdle for them to go through. It's a process.
Well, I think that really puts it into perspective, that there are advantages on both sides, and that certainly the caregivers' needs have to be calculated into whatever decision is made about where such a resident is going to be.
Absolutely.
I think I would just like to add that I'm sort of aware that this progression with the illness can sound pretty dire and scary.
Yes.
So everything else aside, our goal is really to have people be able to have the care and the experiences to be able to have the best quality of life, no matter where they are in terms of the illness itself, and also the different problems that might arise. So we really are looking at trying to figure out the best way to do that, and we're doing a lot more education with everybody on campus in terms of working with dementia. We're really making that a goal, and trying to look at all the different parts of the system to be able to respond optimally, because we know that dementia is a part of the population, in terms of the I guess the amount of illness that's in the community.
It is certainly here.
So we really want to just. I know that one of the biggest and scariest things for the residents is, what if this happens to me, or what if this happens to my spouse,
yes,
or my friend, how can I respond? How is the system going to respond? Is that person less of a person now that they have that diagnosis? So there is that awareness that we really want to be able to continue to respond, in the best way possible to the residents, and again to have those experiences and supports available. So that's a real goal, and we're in the process of doing that. We're not there yet, but it definitely is a goal, and that's a lot of what the whole memory support continuum about, is recognizing that need and developing ways to approach the problem.
Yeah, patient-centered. To bring a patient-centered care. What is appropriate for the patient? Would the patient benefit or the resident benefit aging in his apartment, or because they are residents who do that, and that's when at the very end we also have Green Springs Hospice, which is there to support end-of-life care. So in Green Springs we have all the teams present.
All the pieces
support all the
are needed for support
during the disease process of dementia. So we have all that until end of life. They can, if appropriate, they can choose to do that in their apartment, if all the care needs can be met, or they can do it in the Garden Ridge, either in the memory care unit or in the long-term care, as appropriate.
Well, I think you all have done a wonderful job today, describing the kind of support that is both needed and is provided by Green Springs. So I feel like I have learned a great deal, and I hope our residents have as well. This certainly is an issue that has to be addressed by many folks here. So thank you both so much for coming today, and we'll continue this conversation next time with the memory care unit at Garden Ridge. Thank you, Dr. Bala. Thank you, Kathleen.
Thank you.
You're welcome.
Thank you for watching today, and we'll see you next month.